Good afternoon. My name is Deborah Levine. I am a proud member of the Harlem Hospital Community Advisory Board and also a member of the City University Graduate School of Public Health and Health Policy. It is a true honor today to bring you Tackling Anxiety and Depression, the State of Mental Health in Harlem. On behalf of the Harlem Hospital Community Advisory Board, we welcome you. We're going to give it a few more minutes as our guests are joining us today. We're super excited to have you all as a part of this very important conversation. What you'll see on your screen is our pre-webinar poll. So we ask that you please just give us a few seconds so that you can answer these quick 3 questions. We want to know how you heard about the webinar, what brings you here today, and what organization you're representing. And are there things that you would like to hear us elaborate more as we move through this process? Okay, so seeing that it is now 3 minutes after the hour, we will get started so that we can make sure that we cover all of the material today and our exciting presenters. Next slide. So just a little housekeeping today, as you are continuing to fill out the poll. Today's webinar will be using the Q&A function, and that, for those, if you're not aware, if you move your indicator at the bottom of the screen, you'll see that a toolbar will come up, and there should be a Q&A tab. If you press on that tab, you'll be able to put your questions in that box. Only the moderators will see the questions as they are coming in. And if you can't use the Q&A function at the bottom of your screen, you will see to your left-hand side that there is a QR code that you're able to track the polls and also to use that to enter your questions. So please, as you see through the presentation at any time, please feel free to use that Q&A function so that we can document all the questions that are coming in, some of which we'll be able to answer today. Others we may have to think about doing another webinar or being able to answer as part of our response and thank you. Please note that this webinar today is being recorded and we will be sharing the record feature with you afterwards. Thank you. Next slide. So really quickly, today's agenda is we'll be introducing our first vice chair, Abena Smith, who will be moderating the panel today from the Community Advisory Board. We'll have a presentation by Mr. Padmore John, who's the Assistant Commissioner for the Department of Health and Mental Hygiene's Center for Health Equity and Community Wellness, along with our beloved Dr. Sharif, who is the Director of Psychiatry for the Harlem Hospital Center. It will be followed by a Q&A period moderated by Dr. Ikenna Achebe, who is also a Harlem Hospital Community Advisory Board member. We will be closing out with takeaways by our chair, Karen Dixon, who will give us our takeaways and also be closing us out today. So without further ado, we will move this agenda forward. Abena, it is a pleasure and honor as always. Thank you.
Thank you so much, Deborah. Welcome again, everyone. As you were just told, my name is Abena Smith. I'm the first vice chair of Harlem Hospital Community Advisory Board. We're so happy and excited that you're here to join us as New York City Health and Hospitals Harlem's Community Advisory Board has a discussion on mental health in our community. I will move forward with our program by going to introduce our first speaker. Mr. Padmore John, who is the Assistant Commissioner for Center of Health and Equity and Community Wellness of the Department of Health and Mental Hygiene. I turn it over to you.
Good afternoon. Hi, everyone. Thank you so much, Ms. Smith. Deborah, thank you for the invite. I appreciate the work that Harlem Hospital and the CUNY-SPH, the School of Public Health, has been doing. I'm happy to be here. I also want to stress that I am a resident of Harlem. I live in Harlem, in the West Harlem. I, at one point, was the chair of my community board, Community Board 9. So happy to be around friends and family. I also serve very specifically as part of the Center for Health Equity and Community Wellness, as you very specifically, you said, Assistant Commissioner for the Harlem Bureau. So it's very happy to be able to be here with you all today. I welcome everyone. The next slide, please. So want to just give a really quick background before we dive into very specifically some of the stuff that is impacting Harlem in terms of mental health, but wanted to focus a little bit on some of the work that we do as part of the Center for Health Equity. And it's very important in terms of where we operate and how this has an impact on some of the mental health challenges that we are facing today. So there are three what we call neighborhood health action centers, very specifically as part of our bureaus of neighborhood health. And what we have identified, and this was really a lot of the work done under, started under Commissioner Angela Bassett, Mary Bassett, I'm sorry, who at the time was very specific in terms of identifying some of the challenges that we're seeing for individuals in certain communities and how those challenges, not necessarily dealing with health, has outcomes that are being demonstrated in health disparities. So very specifically, these three neighborhoods are the South Bronx, East and Central Harlem, and Central Brooklyn. In identifying a lot of these disparities, and this is, as you will see here, a little bit of the place, understanding that there's a need for very specific resources in these neighborhoods, and recognizing that there is a highly segregated residentially by race and poverty level, there was a need to have very specific resources and investment in these neighborhoods. Throughout the 70s, 80s, and even continuing today, many of these neighborhoods were disinvested or underinvested in reference to other communities, which led to some of these health disparities that we are seeing. And these health disparities are occurring in mental and physical health. Next slide, please. So as part of a very specific way of addressing some of the challenges that we're seeing in terms of health disparity, there have been very specific resources that have been assigned to some of our neighborhoods. Very specifically in Harlem, as I mentioned, the Bureau of Harlem Neighborhood Health, we have our Harlem Health Action Center. It's very familiar with Deborah and others in the audience in terms of the work that we have done. But the idea is that it's a co-located concept between the Department of Health and community-based organizations that kind of have the opportunity for a one-stop shop addressing a variety of medical health needs as well as social needs. Some of our CBOs are here permanently located in the building, others are in part of what we call as pop-ups. But the intent is just that recognizing that anyone who's coming into our space may have a need for one particular referral, one particular service. There's an opportunity for them to be able to identify a variety of other needs and for them to be in close proximity to these resources. We know that anytime we have to send someone out or there's a distance between some of the needs of these, the ability to get access to these resources, it decreases their ability to get access. So this is a very big aspect of how we are looking to operate. And you see at the bottom there, some of our partners, Public Health Solutions, Concrete Safaris, ABC, which we'll talk about a little bit later. Association to Benefit Children is a big mental health partner here with us. Smart University and ID NYC. Next slide, please. And very quickly, these are some of the services that we offer directly as part of the agency, the Department of Health. Besides a lot of our direct services, these are ways of how we are hoping to support this. And this is really key because we know that they're based on the social determinants of health. These are aspects that are very important in terms of ensuring, making ensure that a community is at its best in terms of health outcomes. Next slide, please. So I wanted to start with substance use in New York City. We'll dial in a little bit further, but this and when we had seen that original map that demonstrated where we have identified a lot of our health disparities. The Department of Health did a lot of research over many years, right, recognized a lot of the spaces where some of these health disparities are occurring. It aligns very much with this map, which is very specifically about substance use. But if you were to look across the board and other health disparities, these kind of occur in the same spaces. And when you go much further back, over 100 years, this perfectly aligns with the redlining that was done in New York City. So some of the outcomes of our health disparities that are occurring today, or mental health disparities that are occurring today, have their inception over 100 years ago. Next slide, please. I wanted to just focus really carefully on this in reference to, so as you see, a lot of these are the top 5 neighborhoods with overdose mortality in New York City. 4 of those 5 are out in Bronx, again in the South Bronx, and one of the highest ones is in East Harlem. So I wanted to ensure that we are being able to focus, in order for us to be able to know where we deploy resources, we need to know where the problems are. And this is really important in terms of ensuring that, in a times of budget crises, that we're making sure that there's an equitable distribution of resources and funding to continue to address some of the challenges that we are facing. So East Harlem has a very high overdose mortality. And we are hoping that as we bring awareness to this, there's a variety of resources that we can bring to address this. Next slide, please. So important for us to know what is causing a lot of these overdose deaths. And this is 2022, of course. It's a little bit challenging to get the more later data for 23, 24. But as soon as we are able to get those, we'll be able to share. And one of the things I do want to be able to do before I finish is to ensure that the community has access to a lot of this data as well. So I want to be able to give that link by the end of my presentation so that folks know how they're able to get this information. But as you can see, many of the opioids and fentanyl are the highest and most involved in some of these overdose deaths. And then we are seeing some of the same things that are happening in Harlem. And this is important because once we know what is the cause, we are able to, again, bring the appropriate resources. And I'll speak about that a little bit later in the presentation. Next slide, please. So just talking to the fact that it's important for us to understand where many of our challenges are coming in. Fentanyl is now entering the New York City drug supply. As many individuals are facing a variety of challenges, they are looking for self-medication. Some of that self-medication is, prescription drugs. Other that is the black market drug supply. But now we're seeing that this is now deadly, right? Where individuals may just go somewhere to get a high for a certain period of time. Now they're putting their lives at risk. And again, once we have a better idea of how we can counter that, obviously the agency, as well as many of the community-based organizations, are now starting to provide fentanyl strips to be able to identify the presence of fentanyl in a variety of various drugs, as well as the distribution of Narcan and naloxone. And we'll speak about that a little bit more. Next slide, please. So the other thing I wanted to take a look at, especially for adults, is psychiatric hospitalizations, and these are the numbers for the 4 community districts of Harlem. Um, 665 is basically where we are seeing the average for New York City. For Manhattan is just just beneath that, 664. For Washington Heights and Morrison Heights, a little bit over. Washington Heights is much less. But for East and Central Harlem, we see that this is so much more, right? And there's a variety of reasons for folks who are ending up in the psychiatric hospitalizations. I also want to stress that this does not include some of the latest numbers. We were able to access that today, but this data does not include the latest numbers from this year. There was a very specific determination made by the mayor in terms of hospitalizations for many individuals, so that does not reflect some of these numbers. With that, of course, we'll be starting to come on a little bit more, but it's important for us just to see. So these are our individuals who have made a determination that they want to be hospitalized or have been asked for their hospitalizations by their families. And we just see just in reference to across the board for Manhattan and New York City, that this is almost twice as much for Central Harlem, and a little bit, just a shade under 3 times as much than from the New York City amount for East Harlem. So there is a variety of reasons behind some of these hospitalizations. One of the key things that the agency is looking at and focusing on about right now is individuals who are just basically do not have, who are completely alone, what we call deep isolation. Being able to ensure that individuals stay in contact with a care member, a family member, a friend, has a significant impact on some of these individuals' outcomes. Whether it's just to be supportive of some of their needs, or be able to help them in terms of accessing a variety of medical and other resources that are supportive of them. But we are starting to see, of course, increasing numbers amongst these psychiatric hospitalizations. Some of this, of course, is absolutely necessary for individuals who have a deep, a variety of mental health illnesses. And these hospitalizations can do a lot in preventing further damage to that particular individual. Next slide, please. For again in adults, and we see take a look at this for children as well in terms of suicidal ideation. Um, that we have very high prevalence for individuals who identify as gay, as lesbian, or bisexual, and it's even higher for those who identify as transgender. So I think, again, as we are seeing that these are very specific populations that are undergoing some of the most significant stress in terms of dealing with the day-to-day situations, these are the individuals that we should be ensuring that they have access to resources, access to support, that there are built-in mechanisms for them to be able to know of the challenges that they are facing, and for them to be able to have access to some amount of help, whether it's a informal help by a friend or very specific help that is occurring through connectivity and referrals to professional assistance. Next slide, please. These are some of the demographics we're seeing for youth in terms of marijuana use, and I wanted to focus on this. As we know, New York State has allowed recreational adult recreational use of marijuana. Um, Unfortunately, at the same time that it has been illegal for adults to utilize, we have seen a proliferation of unsanctioned bodegas and other shops that are springing up that are selling, making easy access to marijuana. So we are obviously taking a very strong look at that in terms of enforcement, ensuring that only those shops that have been approved by New York State. Community boards are very much involved in that process as well. So I think it's and I know Community Board 9, I will have a conversation with Community Board 9 as well as 10. The work that CUNY School of Public Health has done in terms of making sure that there's a greater awareness about what is its outcoming. But we want to ensure that the community is fully aware of access and the appropriate type of access that should be occurring through the legal and sanctioned shops that are popping up. At the bottom of this graph, very specifically looks at those individuals that are within the Health Action Center neighborhoods. For right now, the only place that we're looking at is East and Central Harlem. West Harlem and Washington Heights does not have a very specifically a Health Action Center. But you can see that some of the numbers that are occurring here, much larger amount in the Black and Latino populations in terms of use among youth. Next slide, please. So this here very specifically looks at the sadness, prevalence of sadness amongst youth, and I wanted to focus on this because this leads to a lot more negative outcomes if it is not appropriately addressed at the appropriate time. As you can see, some of the in terms of for that age group between 14 and 18, well over 30% for all of the age groups in terms of prevalence of sadness, highest within Manhattan, highest for the Latino population within this age group. And then again, in reference to East and Central Harlem, we're seeing it almost at 40% for the Latino population and over 33% for the African American population. Again, best for us to be able to identify where some of the challenges that we're seeing, how we are able to ensure that these particular individuals, these young kids, are able to get support and help very early. Feeling of sadness, unfortunately, leads to much worse outcomes. Next slide, please. And some of these outcomes are represented here very specifically in terms of suicide attempts and ideations. We have seen a significant jump among the African American community for youth that are indicating that the prevalence of sadness and hopelessness. For 2019 it was 34%, and 2021 it's now 41%. So, and you can see that the trends, although some more or less staying stable, there is slight increases. Again, for us, and I want to, very specifically focus on, feeling sad and hopeless. When individuals enter that space, it is very difficult. They need to be addressed as quickly as possible so that we can prevent individuals thinking and going into the suicidal ideations and attempts as we are seeing. So very important for us to be taking paying attention to. Next slide, please. Again, these are some of the user sites we're seeing. What this is showing is from some of the previous years, looking for those very specific numbers are for these particular populations. In the middle, the Black and Hispanic population. The shaded, the dotted line talks to the 2015-2019 average. In some instances, for a Hispanic Latino population, for example, it has increased for the number of confirmed suicides by race and ethnicity. It's pretty much a little bit same for African Americans. From 18 to 24, it actually has increased. That should be a little bit larger. So again, being able to be very specific in terms of our age groups and the individuals that we know need the most help within our communities. Next slide, please. So obviously, these are some of the challenges that we are facing. For wherever there's a challenge, we need to be able to identify resources. 988 is now the city's preeminent resource and access addressing suicide crisis and mental health needs in general. For 988 is able for you to connect free, private, in ways to be supportive of your various needs. Just because of the variety of ways of how we, from the various age group, you can get it via phone, you can text, or you can chat. It's something that we know even during times of emergency, that for you to be able to respond, there's the various counselors that are on emergency response to this, but also to be able to have ongoing access to mental health support. Um, it has definitely improved. We're just trying to get some of the numbers in terms of its use and some of the outcomes of the use, so that those are not available as yet. But as Deborah said, it's either for us to be able to have a follow-up mental health support or conference again, or to be able to provide that information as is made available. And I'd like to just dive into some of the other resources that are available as well. Next slide, please. So this is these are not clickable, but when you go into 988, these are all the variety of methodologies for youth to be able to be engaged, so that there is an opportunity for being able to get supported. We know that not all youth are the same, that there are a variety of the ways that they accept help. Not all youth ask for help the same way. Not all youth want to be helped in the same way. And so this is a list of resources that has been put together underneath the 988 umbrella. Some of them is very specifically done in coordination with partners. Some are cartoons, some of them are engagement one-on-one with individuals, some of them are groups. We here at our Acton Center, we have begun healing circles work to be able to be supportive of youth as well. So, and this is also exemplified in some of the resources that are available here. I think it's important for us to recognize that youth come to get help in different ways, right? So it's not a cookie cutter where one thing works for everyone. The other thing is that some youth are because of the different support that they have around them, are willing and able to ask for help. Others are not. So being able to have the variety of resources that engages individuals in the way that they're best able to be supportive of receiving the assistance is important. And I wanted to just stress that it's okay for you, for if you are someone who are able to make this connection to youth, for some of these resources to go into them, you see that they're very different. You may know that individual a little bit better to say this one is better for you based on what it is, but also to just encourage this particular individual to be able to try the different ones to see which is the best way for them to get that assistance. Next slide, please. So we had mentioned one of the highest causes of death for our neighborhoods here in East and Central Harlem, as well as other spaces, has been around opioid. Naloxone is the great cure. It can be applied when anyone has awareness that someone has been overdosed on opioid. There are no known negative effects to this. We do trainings here at the Health Action Center. There are a lot of other community organizations that also do training, distribute the Narcan. So it's something I encourage everyone to have. I always walk around with a pack in my bag just in case. This is not something as an indication, and I know one of the things that we're going to be talking about is stigma. But we cannot say we didn't want to carry this thinking someone is going to look at us in some way when this is what can save someone's life. So I ask that we all have one of these cases in our bags, in our purses, for whatever situation we may run into. Next slide, please. And I understand I know I'm running out of time. These are some resources. I just want to go through some of these resources that are available. I believe Deborah is going to share the links later on, but of course, Harlem Hospital as well. You can go to the next slide as well. In terms of some of the resources that are available. And some of these are community-based organizations. Some of these are being done by the New York City Health and Hospital as well. I think that's it. If there may be one or more, one or two more. You can go to the next slide. Yes, I think that's it. Thank you so much. I do just want to say, in terms of accessing the data, it's called EpiQuery. I'll put a link. I'll ask our moderator to put the link in the chat. But it's data that can be accessible by anyone in the community. And I think it's very important, especially for community districts, community boards, community advisory boards, to be able to make decisions on how to assist some of our mental health, our public institutions, our individuals who are in charge of the budget, to be able to make the appropriate decisions, and those decisions should be based on data. It's important that our community boards or representatives have access to that, so I'm happy to share that out later. Thank you so much. I appreciate your being here and listening.
I want to thank you so much, Padmore, for your presentation. It was really thorough and dynamic. You definitely brought forth your expertise from what you know, your knowledge base, your career, and specifically from the platform, the Department of Health and Mental Hygiene. Thank you so much. This is what we're here for. You brought the data and you also brought the resources. Thank you. All right, so this discussion continues, and we will be hearing from another expert, specifically Harlem Hospital's own, who is here to join us right now. He's appeared on the screen. We're so excited, and you all will be excited too when you hear from Dr. Sharif. And he is the director of psychiatry for Harlem Hospital Center, and his team will join him. And I will leave that to him to introduce them as he invites his team to also participate in the discussion and have us all to be more informed. Thank you. I turn it over to you, Dr. Sharif.
Thank you. First of all, thanks to Commissioner Padmore for the very nice summary that he gave about the magnitude of the challenges that we face in our community. So I think that's a great backdrop to see that, you know, the bigger picture of mental health in the Harlem community and all the real challenges that we face in trying to overcome the obstacles that people face in getting the care that they need. So first, I want to also thank Deborah Levine and Ike and Abena. I mean, we go back a long way. We've been doing different things to try and get this information out there and to engage with the community so that we can really improve access to care. I mean, our hospital is a community hospital. And sometimes, you know, this is not clearly evident and is not stated enough. Mr. LeConte, who's our CEO for the new CEO for the last year and a half, constantly makes this point to us as leaders, the clinical leaders, that our commitment to the community has to be first. Now, I have always been committed, but you know, it's a change that we are going through in terms of really reaching out and making these connections, which I hope this is one of the first efforts at this. For the psychiatry department, we've done a few things in the past, but I think this is the beginning of a new phase where we hope we can be much more effective in making these bridges and connections that eventually can get patients and people, I don't even want to use the word patients, but people who need the care to get them into care that is appropriate for what their condition is. Now, I took over the position of leadership in psychiatry here in 2010. But I go back with Harlem till as far back as 1984. So I actually did my residency here. I got my start in psychiatry here at Harlem Hospital. And then I went up to Columbia for about 20 years or so, and then I came back. We have seen a lot of changes over in our department in the last 10, 12 years. We are actually expanding many services. Our staffing is very good at this point, and we are really set, I think, as a department, we are set to really expand our services. We've expanded them, but to get them to the people, get the message out so that we can work together to provide these services to people who need them. Now, what I'm going to do, we're going to talk about depression, anxiety today, mostly, not about all of mental health. I will give a little bit of an overview to put things in context. I want to start off by just setting out the landscape that we are going to be talking about. And then I'm going to hand it over to one of our attendings in the outpatient department, that's Judy Burke, Dr. Judy Burke. She will talk a little bit more about the actual symptoms and the conditions of anxiety and depression. And then Dr. Hashim, who is my deputy, is second in command of our department. And he has really, over the last 6-8 months, has been responsible for revamping and restructuring our outpatient services so that they become much more customer oriented, more accessible, and that we are better able to match the specific treatments or interventions that a person needs with what their clinical condition is. So our outpatient department has really gone through a lot of changes, and I think we are in a very good place at this point. All right, so with this said as introduction, let me go to let me have the first slide. Let's look at that. And some of this data that was covered by Commissioner Burke. This is Commissioner Padmore, but I want to share this with you just to set the big picture. This is national data. It's not the Harlem community data. This is for the whole country. And this goes to, you can see the date on top is 2021. And this, what you're looking at here is what percentage of the population received a mental health service or a contact in the preceding 12 months before this interview was done. Now, if you look on the left bar, basically all these numbers are close to like 50%. 1 in 2 people had a mental health contact in the preceding 12 months in the United States. I mean, that is shockingly high because we don't think the prevalence of mental illness is 50%. But this really shows that it's not just what the diagnoses that we have that characterize serious mental illness that we have to focus on, but all the challenges that people face that may not meet the threshold of a psychiatric diagnosis, but still people would benefit from a mental health intervention. So this speaks to the issue of what are the boundaries of our psychiatric disorders? How do we define them? You know, most psychiatric disorders are behavioral manifestations of illness. So the behavior of the patient changes, how they feel, their emotional state, that can change. These are difficult things to quantify like we do in the rest of medicine. You know, you have an abnormal lab value, you have an abnormal CT scan. It's very easy in the rest of medicine to characterize what is disease pathology from what is normal function. In mental illness, we have to think in different ways to really characterize what is it that we can help with, as opposed to, is this person mentally ill? Or what are the conditions that we can help with, that we have known treatments for, that may be time limited, that don't have to be lifelong, that can get people through difficult times. So we have to change our mindset a little bit as we think about this. And this speaks to the magnitude of the challenges that people have out there, 50%. Now, the second important point on this slide I want to make is, first of all, male, female, you can see the next 2 bars. Females a little bit higher than males. Frankly, in terms of serious mental illness, there is very little sex difference, if any. But for more milder forms of illness or challenges like depression or anxiety, they are more common in females than males. So that's another point here that there is a sex difference in terms of milder forms of mental illness. And I won't call it mental illness, but conditions requiring intervention. Now we go to the last point I want to make here is, or the last 2 points. One is the age is not really a big issue. You can see from 18 all the way to above 50 is basically the same, about half of the population. Those are the next dark blue bars that you see. Age doesn't really matter. The prevalence is about the same. The important point here is look at race and ethnicity. White is 52%. Now, whites are 65% of the population. 52% of them get access to care. In the African-American community is 40%. This speaks to access. One of the main things we are here for is access, making it easier for people to get care, making it easier or make them convey information so people are able to recognize when there is something that they could get help with, and then getting them the care that they actually need. And this slide shows this in stark numbers. When you look at 52% versus 39% here, it may not look like much, but just do the proportional math here and you can see that there is a 20% reduction in access to care. 20%. That is huge. And it is something that we as a group, I think, need to remember and keep in our forefront as we have these programs and we set up the systems for referral of patients and to get them the care they need, that access is one of the biggest challenges that we face. Now, I will come a little bit later after the next slide, I'll come to how we define mental illness, because I think it's important to just have that concept because not everything needs a diagnosis for help to occur and assistance to be given. So I'll come back to that in a minute. Let's go to the next slide. This one is very brief. It's about children. Look at children. 50%. What is even more disturbing on this slide and concerning is that look at the second bar. 22% of kids have severe impairment. Folks, we have seen this in our emergency room, especially after COVID. We see an average of anywhere between 2 and 4 kids a day presenting in our pediatric emergency room in a mental health crisis. Associated with this is a dramatic rise in suicide completion rates. And guess which population subset of the population is at highest risk? In the last 10, 15 years, we've seen a dramatic increase in adolescent Black male suicide. Specifically in this population group subset, we are seeing a dramatic increase in suicide completion rates. So this is something we are working with the NYU on. NYU, New York University, has a grant from the federal government, so we are part of that, and Kings County, another hospital that serves a predominantly African-American population. We are both collaborating with NYU to try and understand this phenomenon of why is there been this increase and what can we do about it. So hopefully over the next couple of years, we'll get some data from this. All right, I'm going to skip the next slide. You can show it, but it's basically what I just talked about, suicide. And let me now just talk about how we define mental illness. And then I'll hand it over to Dr. Burke to get a little bit more into the symptoms and presentation of anxiety and depressive disorders. So if you look at serious mental illness, that's usually what the population thinks about of mental illness. This is schizophrenia, bipolar disorder, serious depression. If you look at those diseases, they really are brain diseases. Serious mental illness is a brain disease. If you look at the sex distribution, not really different. Male, females are the same. If you look at the rates of schizophrenia and bipolar disorder all across the world, they're fairly similar. It doesn't matter which population you look at. Is it an urban population? Is it a rural population? Is it a developing country? Is it an industrialized nation? It doesn't really matter. The serious mental illnesses are all about the same all across the world. So what does that tell us? Those real serious diseases are mostly, their cause is mostly genetic and brain dysfunction. It's part of the human experience. The part of the human genome is those conditions that are what we see, very serious mental illness. People who hallucinate, who are delusional, you completely lose contact with reality. When we have that serious mental illness, it's impressive how uniform it is all across the world. So then we look at the other category of patients. If you look at the numbers of this, 1% of the patient have schizophrenia of the population. Maybe 1.5% have serious bipolar disorder. Same with major depression, that is very serious major depression. This is an illness where people just, stop eating. It can be so bad, they stop eating, they don't move. Those types of disorders, if you look at them, they account for maybe all of them put together, maybe 3 to 5% of the population. We saw that 50% of the population got some contact with mental health. So who are all these other people who are seeking help? This is where we see symptoms that have occurred or conditions that have occurred in people who are doing okay, but then have tipped over into a place of problem where they're having problems. Now, what are these? How do we define that a person needs help or treatment? We look at two things. First, we look at the subjective distress. How much is the person suffering from the symptoms they're experiencing? And the second thing we look at is the whatever is happening, is it affecting the functioning of that person? Now, functioning, there's a role functioning. So role as a parent, role as a social contacts or, just friends, your role as is working. So the different roles we all have, if you have role impairment, functional impairment in role functioning, and or you have subjective distress, you're really bothered by the symptoms you experience, that's the threshold for us that warrants intervention or treatment from us, help from us. This doesn't require a diagnosis. Now, insurance companies, to get paid, we have to go to diagnosis, but by and large, we don't go with diagnosis, we go with these two things: impairment of function and subjective distress. Now, if you look at depression, if somebody is hallucinating, that's not a normal human experience. Or if you're delusional and you think somebody's trying to kill you, those are not part of the normal human brain function. Depression is a normal human emotion. We all have it. We all feel depressed now and then. We all feel anxious now and then. These are, on an evolutionary basis, these are part of the human experience. So when do they go into a zone of impairment? When do they go there? Well, that depends on your biology. I'm not saying they're not biological at all. They have some biological component, but there are also all the other mitigating factors that interact with this vulnerability to create a condition. And those are factors such as what were your challenges in your upbringing? What are your coping mechanisms? What is your support system? What is your faith and religion, your adherence to that, and the comfort you get from that? What is your social network that helps to counter some of these challenges that people feel or face in the community, like our community here? There are a lot of real world, real life challenges that people have. They may be facing eviction, they may be facing drug use around them, they may be facing financial stress, social stress. Kids are not doing good. They pile on top of each other. And at what point does that become something that starts impairing your function and disturbing you tremendously in terms of distress? That varies for person to person based on what their resilience is. So this is where I will actually stop here, just to give you a sense of that you don't need to have a diagnosis. We have to think broadly about this, and we have to create education around these topics so that people don't or at least we have reduced stigma around seeking mental health. This is the dimension of mental health that doesn't always fall clearly in mental illness, but we can still help. Psychotherapy can help, different forms of psychotherapy. Few patients, even this category, may need medications, but it's not one size fits all. And definitely, we don't want to give medications unless people actually need it. So let me hand over to Dr. Burke now. She's one of our attending psychiatrists, as I mentioned. She will take us through a little bit more about the symptoms and how this manifests clinically. Judy?
Thank you, Dr. Sharif. My name is Judy Burke. I'm one of the attending physicians, and I work directly with patients in our outpatient clinic. And I also supervise many of our residents in training by helping them with the clinical management of their patients. So patients from the community come to our clinic for both initial evaluation and for continued management of their mental health conditions. People are seen at different intervals. For example, people at just the beginning of their treatment or who are in the process of adjusting their treatment or medications might be seen more frequently, maybe every 2 weeks or monthly. And we have very stable patients who might only come to us about once every 3 months for maintenance checks. So some patients are seen for medication management alone. Others come for individual or group therapy. Those seen for individual therapy might be seen weekly or every 2 weeks. So we see patients in person in our clinic, and when appropriate, we can also offer video visits with patients who are home or who are located in another private location, just as long as they're within New York State. So I'd like to talk to you about commonly seen conditions in our clinic. And two of the major categories of presentations fall under the broad umbrellas of depression and anxiety. And now within those realms, we do see a full spectrum of symptom severity. And that's where psychiatric evaluation can play an important role. We can help people to distinguish between what's a normal difficulty and what's a clinically treatable condition. Now we can do this through clinical interviews, and sometimes we use validated scales or screening tools. So perhaps you've heard of diagnoses like major depressive disorder, generalized anxiety disorder, panic disorder. These are examples of clinically treatable conditions. And they really distinguish themselves from occasional low mood or transient anxiety in that they tend to be more persistent, more disabling, and more likely to change how an individual is functioning and feeling in their lives over a longer period of time. So clinical depression can present very differently for people. Typically, we diagnose depression based on a patient's self-report of symptoms. We look for low mood, changes in sleep, appetite, or energy, trouble with concentration or focus, feelings of hopelessness or worthlessness, loss of interest in things that they used to enjoy, or maybe even thoughts that their life is no longer worth living. And when several of these symptoms persist in combination, lasting for most of the day, nearly every day for 2 weeks or more, with that subjective distress and change in ability to fulfill one's own role or function, we consider that patient might be having an episode of what we call the major depressive disorder. And what does an anxiety disorder look like when it's a clinical condition? It's when anxiety becomes more than occasional worry. It's when worry becomes persistent and disabling on most days for at least 6 months. Patients might describe symptoms like, again, trouble with focusing and making decisions, feeling keyed up and irritable, impatient, maybe having muscle tension, headaches, feeling physically and mentally exhausted, but somehow unable to relax. So why did these conditions develop? We think it might emerge from a complex interaction of factors, including social, psychological, and biological, or what's inherited. People who've had difficult life events, for example, unemployment, housing instability, bereavement, trauma, even divorce or illness, they can be more likely to develop depression or anxiety symptoms. And untreated, this can lead to more stress and dysfunction, which can then worsen the life situation and then the condition itself. It's possible that anxiety disorders develop when people find their level of perceived stress has exceeded their ability to cope. Anxiety disorders also tend to run in families and tend to be more common in women. So we know that depression and anxiety can be related to one's physical health, people with cardiovascular disease, diabetes, cancer, respiratory illnesses, or other chronic conditions may find themselves experiencing mood or anxiety symptoms related to these conditions. Also, behaviors such as lack of physical activity, use of alcohol or illicit drugs can affect one's physical health, further contributing to mood symptoms. So psychiatrists are medical doctors, and so another important role that we play is finding out about our patients' physical health and how health conditions might play a role in mood and functioning. Some medical conditions can mimic psychiatric conditions. For example, thyroid dysfunction could cause mood symptoms, possibly depressive symptoms, or even mimicking symptoms of anxiety. So we do require that when people come into our clinic to establish care, that they are connected with a primary care physician for regular management of their comprehensive health. And we can provide referrals for those who need assistance with getting connected to primary care. With information about our patient's physical health, we can then make informed decisions about their diagnoses, about treatment options, if we're prescribing medications, which ones will be most appropriate. We'll also be able to coordinate with primary care if we're prescribing medications that might require some more regular health monitoring. So we acknowledge that there can be significant stigma around mental illness, and perhaps for depression in particular. Some people might feel embarrassed or guilty or confused by their symptoms. They might think, I must be weak or ungrateful. They might feel the need to push through their symptoms, thinking, well, it's time to be depressed. I have a family to take care of. The reality is that in some communities, that confronting systemic and interpersonal racism, discrimination, sexism, or gender-related violence on a regular basis, in the absence of adequate supports, can result in increased vulnerability to having anxiety or depressive disorders. So depression as a clinical condition is not uncommon. About 8.3% of American adults have had at least one major depressive episode. Anxiety disorders are even more prevalent. 19% of US adults had an anxiety disorder in the past year, and 31% will experience one at some point in their lives. More women are affected by them than men. The good news is that these are clinically treatable conditions, and there are treatment options available for mild, moderate, and severe symptoms. And although treatment is available, many people don't get it, perhaps due to the social stigma associated with accessing mental health care, or the idea that one should just tough it out. Or maybe it's that they just don't know how or where to get help. Treatment may or may not involve medications. Psychological treatments or therapy can be a good first-line option for managing depression and anxiety. During therapy, patients can learn new ways of thinking and coping or relating to others. And over time, with practice, patients can experience more resilience and remission of their symptoms. For some patients, medications might be appropriate, or therapy can be combined with medication. Sometimes medications can reduce severity of symptoms, allowing people to follow a daily routine again, help with sleep or restlessness, reduce suicidal thoughts. And symptom reduction can then lead to implementation of positive behavioral changes that can lead to long-term improvements in mood and function. So because so many patients might not, or so many people might not know how or where to begin to get help, we'd like to take this opportunity to show you some of the many services available here at Harlem Hospital. So I'd like to turn the discussion over to Dr. Hashim, who will describe how to access the care that we have. Thank you.
Good afternoon, everyone. Thank you, Dr. Burke, and Commissioner Padmore, Dr. Sharif. You heard our first two presenters give you the scope of the problem that we're dealing with, and a good description of where we're of the actual illnesses and some of the treatments that are used from Dr. Burke. And for this part of the presentation, I wanted to, as Dr. Burke said, to show you exactly what this means in real time. And over the last 2 years, we've been working on access, not just here, with also what we call our central office. And there was a year of planning into this, and then we launched on actually May 8th of last year, and we're coming up on our anniversary here in 1 week. And we piloted the program for the entire system, and it's actually multiplied all over health and hospitals, and it's been quite successful. So, so this is the actual building. That is exactly where the clinic is. That mural over there on the 5th floor, that is where my office is and where Dr. Burke's office is, and that is the entrance to the clinic. So I just want you guys to get a picture of what it really looks like. So what departments are within our outpatient clinic? It is it's comprised really of 3 different departments, all housed on the same floor, and that's the adult outpatient psychiatry department, the chemical dependency and ambulatory detox clinic, and the integrated outpatient services. Basically, this is a brand new, about a year or 2 years old primary care clinic that's housed within the same floor as the other 2 clinics. And it's dedicated to our population of patients, just to be able to better meet their special needs. Because a lot of them don't like to go to primary care doctors, and we're able to actually service them in-house with our nursing staff that they're familiar with and some of the doctors here. Next slide, please. So who do we treat? We treat everybody 18 and up, but that's not only what we do. We also have a specialized populations that we kind of dedicate a team to. So we have a geriatric psychiatry clinic for people who are 64 and above. And we have a board certified psychiatrist in geriatric psychiatry is managing the clinic along with residents. We also have the child psychiatry clinic, which is housed in Ron Brown building around the corner, and they see everybody 17 and under. And some of the challenges that we've been working on system-wide, especially here, is languages, is barriers to care, like language and cultural backgrounds. We take everybody from every language. We have interpreters on site. We have interpreters through the internet. We also have interpreters by phone. We can call family for collaterals who do not speak the language, also to better serve our community. Next slide, please. So what do we treat in OPD and AOPD, which is the Adult Outpatient Psychiatry Department? Dr. Burke touched on some of this, but you know, we treat depressive disorders, anxiety disorders, schizophrenia, bipolar, obsessive compulsive disorder, PTSD, behavioral symptoms of dementia in our geriatric psychiatry clinic, adjustment disorder reaction. But really, we don't just treat those. We also treat what most people come into the clinic for is grief, recent trauma. People don't come in and say, I have an anxiety disorder or depressive disorder. They come in with a certain complaint, and we do manage all of that here, and we see people for difficult life transitions as well, such as changes from moving here. We have some immigrants that have come here that we're helping as well, and we have patients who go on to a divorce. That kind, those challenges that they have in their life, and we try to meet them with it. We have dedicated teams of social workers, community health workers, who are also there to help with concrete services to address some of these difficult life transitions. Next slide, please. So the reason we're here is to also communicate with the community how you're able to reach us, how you're able to get to an appointment. The whole project with Access over the last 2 years was designed for this. We have trained and cross-trained all our administrative staff in the front desk to be able to field any call from the community. And we have referral queues internally as well, and from clinics, in order to handle referrals going forward. So the main number to call is this one. It's 212-939-3210. If you know Harlem, all our numbers start with 212-939. This is the specific extension to our front desk. And anybody from the front desk can field it, and they can give you an appointment, whatever's available in the system we created, which could be up to 2 months for like non-urgent cases. But if you have any urgent cases that need to be seen quickly in the outpatient clinic, I'm providing you all with also the information for our intake coordinators, Ms. LeBron and Ms. Barco, will back each other up even if somebody's not there, and their emails will be available to you. Next slide, please. So this is the contact card. If you remember anything from what I'm saying, which at all, this is it. This is exactly how you're able to get a hold of, to get an appointment with our different departments. This is the AOPD is the main psychiatry clinic again, the chemical dependency and child psychiatry clinic. And I think the slides and resources will be provided to you after the presentations as well. But they are all trained, they're all supervisors, and they're all able to manage, triage the not complaints, but to the needs of each patient, whether it needs to be seen quickly in a day or two to override the schedule, or it doesn't, or if you don't really need psychiatric care, we have a collaborative care clinic, which is, we don't have enough time to discuss here, but that's also for patients who have some mild forms of anxiety, but don't want to see a psychiatrist, see a primary care clinician initially. But we'll provide this contact card after the presentation. Next slide, please. So what do you expect on the first visit, which is what we call the intake? This is our lobby. This is where you enter to come to see the staff here. The first day is a little bit longer. It's because we have a comprehensive service here where we have nursing, we have psychologists, social workers. Most private psychiatrists don't have the time to see anybody this long. They only spend an hour, but for us, we're able to have you get assessed for many things on the first day. And the first thing that you do is you will meet a nurse and an RN, which we also started that clinic about a year ago. And they will do a battery of assessments, and they will discuss your medical history, whether you have a primary care physician, and they'll do a nutrition assessment with you. And all these assessments will be, and they'll take your blood pressure, make sure you're physically stable, and then they will pass on the information through our electronic medical record to the provider who you'll be seeing next. The next visit will be with the clinician, which is about 90 minutes, and that is your initial assessment. Could be a psychiatrist, social worker, psychologist. They're all supervised by board-certified psychiatrists in each intake, and a decision's made between you and the clinician, how you would like to proceed, what kind of treatment you would like. There will be short-term, at least, goals set in that first meeting, but you'll be working on your treatment plan goals as you go for every visit. But you'll set the course for your treatment going forward on that visit, and the appointments after that will be decided between you and your clinician, and how often you need to be seen, as Dr. Burke said, whether it be weekly or monthly or every 2 weeks or longer. Next slide, please. So these are the broad range of available treatments. I think Dr. Burke touched on some of these, and these will be decided on your intake day or consequently the second or third visit, depending on what you need. You've got the class of medications, antidepressants or anxiolytics that are usually for depression or anxiety disorders. There are other classes of medication for different disorders, but for the purpose of this presentation, these are the ones that are usually available. And some of the therapies that are available in our clinic, and what they mean. A supportive therapy, for example, is used for emotional support to address self-esteem issues or short-term distress in your life that needs to be supported at that time. Cognitive behavioral therapy, it's a more structured type of therapy, and that kind of therapy is there to change thought process in order to so you're able to function. And it's usually used for like anxiety disorders and depressive disorders. Trauma-informed therapy the goal of that is to make you feel safe. If you have a history of trauma or PTSD, the goal is for you to feel safe in an environment and to be able to see how the trauma affects your interactions with people. And psychodynamic therapy is what we historically have seen what therapy is in movies like Freud, but these are shorter term, psychodynamic versus psychoanalytic. It's about a year. It's a little longer than the other therapies, but it focuses more on your relationships with your that you had growing up and how they affect your life going forward. And groups, we have a wellness group at this time and the grief group. We'd like to add more groups, but we lost some groups after the pandemic because the patients did not want to come in, but we have future plans to get a medication side effect group, education about, and then a young adult group. So this is for the future. Next slide, please. So what can you expect of treatment? I think Dr. Burke touched on this. What we call short-term therapy is around 6 weeks. And that just depends on your goals and what you're trying to achieve based on your intake appointment and what you plan with your doctor. Long-term, year or longer. So some patients have depression that lasts a long time, or they have it for a certain period, they improve, and then it returns. So they might need a longer time to address the depression. Frequency, again, weekly, bi-weekly, monthly, or longer. I've had patients who started weekly, went bi-weekly, monthly, and at the end they were every 3 months. Every 3 months, every 3 month appointments are for very stable patients. It's not what we usually do, but that's the maximum time you can go without seeing your provider in Harlem. And the treatment setting is, again, it's in person or remote. We actually all put this together in the last year. The video interviews are streamlined. You basically just receive a text straight to your smartphone and you just hit the button and it activates it. It's not cumbersome at all for patients. It's very helpful. And if you fit the criteria to do video visits, then you'll work that out with your provider. And the only thing is that the first visit has to be in person so they can assess you properly. And thank you. Appreciate it.
I want to thank you so much. Thank you, Dr. Sharif, your entire team, Dr. Judy Burke, Dr. Hashem. Very in-depth and thorough and absolutely exceptional work that's going on in your department. And we appreciate you all for sharing it. But we're going to now get right to, I'm going to introduce my fellow peer cab member, Dr. Ikenna Achebe. He's going to take question and answer period. And I'm sure that's what the folk have been waiting for. Thank you.
Yes. Hello, everyone. Thank you, Abena, for introducing me. Hello, everyone. My name is Dr. Ikenna Achebe. Like Abena said, I'm a member of the Community Advisory Board, and I'm going to just jump into our question and answers. And so we actually already had some questions and answers questions that we wanted to prompt, but there was a question that was earlier put in the chat, and so I'm going to start with that question. And so, Mr. Padmore, Dr. Sharif, please feel free to answer. And so that question was: are these services available for residents from other boroughs or only Manhattan?
Oh yeah, the services are available to anybody. Now, generally, we try and do it that people get care because we have hospitals in the system all over the city, that they get care near where they live. But there are no restrictions in terms of catchment areas. We do have people coming from, there are not many, but people who do come from other boroughs, and we take them, so.
Okay, got
Yeah,
it.
I'll just jump in really quick. I'll just say, yeah, the same, especially for the Action Center in terms of some of the training, some of the resources that are available, as well as being able to access some of the information that's definitely done across other boroughs. Very specifically for us, the Department of Health, the Center for Health Equity and Community Wellness, there is action centers in the South Bronx and in Central Brooklyn. We are also engaging residents in Queens. Unfortunately, we don't have any representatives in Staten Island at the moment, But I think it's also important to recognize that individuals, when they don't have to travel that far to a resource, it's easier for them to access it. So being able to have resources much more easy and accessible closer to them is also beneficial. One of the reasons why we have these action centers in neighborhoods that we know undergo so much disparities in health and mental health needs. So there is a lot more to be done in terms of making sure that there's more of these action centers, more resources available, but we definitely accept anyone from any of the boroughs.
Got it. Thank you so much for those answers. And so the next question that we had was, what specific challenges do residents of Harlem and Upper Manhattan face in accessing mental health resources and support for anxiety and depression?
Judy, do you want to take this, or I can do it? I don't want it to be just me answering the questions.
Oh, no, please go ahead, Dr. Sharif.
All right. So the question was, what are the challenges they face in accessing? So you can look at this if we put ourselves in the shoes of the person who's affected by these conditions, is the first thing is to recognize that something is going on that you can get help for. So first is recognition. Now, recognition comes from education, from different resources, from people around you. Many times people around you see the problem before you feel it or you recognize it. So I think education is a huge component, has a huge role to play in the first step of getting care, which is recognition that there's a problem that I can get help for. So then the second part is, what can I get help for, right? That is another knowledge-based issue. So what are the kind of things that I can get help with that will improve this condition that I have? So if somebody is having, for example, loss, I mean, we have a lot of mothers in the community who have had children who've been shot or otherwise traumatized. I mean, at any given time, we have 3-4 kids in our pediatric service who have been either assaulted or shot. Or so, if you look at the trauma and the stress of this on the parent, and you'll say, well, I'm normal. But when does that coping mechanism get overwhelmed, and that we could really help professionally in that situation, as opposed to just, as Judy said, trudging along and trying to just power through it? So that's the second part. What kind of treatment is available? And then comes the last step, which is, how do you reach the clinic? We only touched on the last part, right? This is our numbers, these are the people you call. But long before that is the work that has to be done in educating the community in terms of what these symptoms are, how do these illnesses present themselves, what kind of treatment is available, and reducing the stigma to get people to take that first step. And much of this has to be done at a community level, meaning at community boards, at the housing agencies, where the people are, that we can coordinate with those to have these educational sessions. Now with Zoom and all this has become much easier. But we even used to go, before COVID, we would go out into the community and do these live interactions. I'd be happy to do that, to get this ball rolling in terms of working with the community leaders and people who are interested to get the message out.
Thank you so much, Dr. Sharif. And okay, and so this next question is going to be open to any of the providers that we heard from earlier. We want to know, so what efforts are being made to ensure that outpatient mental health services are inclusive and responsive to the diverse needs of the local community, including considerations of language, culture, and socioeconomic status?
I could speak to this. So the first thing that we did, and we've been working on, and that I mentioned it, I think, through my slides, is that interpreter services. It was, when I started here, it was only live and in person, and we sometimes would have difficulties finding anybody to come at that time when a patient's need. But that's changed, especially with technology. We have specifically for outpatient services, everybody on their desktop now has access to interpreters immediately with the push of a button. So if you're sitting with any patient who speaks a different language, you're able to interact with them. And they're even some dialects services that are not available, they will locate somebody for you. So in addition, we have a green iPad that rolls around outside right behind me in the clinic, and it's brought in. You can bring it into any office and immediately get interpreter services with just a press of a button. So we identify those in every initial assessment. The language is one of the first questions that we have a hard stop, is what we call it here at Harlem, when you're not able to skip this button to be able to identify somebody with a language disparity. Cultural backgrounds, we have a diverse staff here at Harlem of people with different cultural backgrounds. And we actually, during the intake process, we try to identify if they have specific choices of who they want to see, whether it be male, female, different culture. We have different providers here with different religious backgrounds. So we're able to match those actually quite well at Harlem, which is wonderful. And the last one is for people with different socioeconomic status. We are open and we serve everybody in the community, and people, for example, we have a lot of patients who come from our emergency rooms who are in shelters or homeless at the time, and we have a lot of services here through social work and community health workers. We've actually hired more community health workers, which provide concrete services to people, and we have community liaison workers who are licensed providers who are able to provide higher concrete services and wraparound services after care. And we have licensed social workers, clinical licensed social workers, and all of them are available to take care of a patient. And I'll give you a good example. I had a patient of mine who was 70 years old, and he was in an apartment building where the noise was too much, and he was in distress because of auditory hallucinations, wasn't able to sleep at all. So he had a dog, and he got finally a place. We applied for him here through these services to get a new apartment with NYCHA. They accepted him, but after a year of hard work and finally getting to this point, they refused him based on his dog. We involved everybody in this because he was grandfathered in, and we got him his apartment. And the impact this had on his mental health is unbelievable. I mean, he is really stabilized and improved. So these are some of the things that we do here. I've had a patient who I've sent to one of the CHWs, and he helped him with his taxes. That's not a joke. It's a serious thing. So we have all of these things provided at Harlem. So hopefully that answers the question.
Yes, it did. Thank you so much. And so in consideration of time, what I'm going to do now is go to Deborah, who will now.
Thank you, and thank you all for your presentations. It gives me great honor and privilege to bring up our chair, Karen Dixon, who is the chair of the Harlem Hospital Community Advisory Board, who will do the takeaways and closing remarks. Thank you, Chair Dixon.
Good afternoon, everyone. This was a wonderful webinar. As I said, my name is Karen Dixon. I am the chair of the Harlem Hospital Community Advisory Board, and I also chair all of New York City Health and Hospital Community Advisory Board. This event was important to us because based on the data that you've seen today, it highlights a need that's in our community. And so we wanted to be able to start to share resources and bring the community, make the community aware of the resources that are present at our beloved facility. I'd like to thank Mr. George LeConte, our CEO of the facility, as well as Dr. Sharif and his team, Dr. Burke and Dr. Hashem. Definitely Assistant Commissioner Padmore John, the data that he provided on a local level, particularly for East Harlem and Central Harlem, was quite informative, whereas Dr. Sharif's data on nationwide information was also equally informative, especially in highlighting the issues around access for Black and Latino individuals. I also would like to thank the Harlem Hospital Community Advisory Board, as well as the Mental Health Committee Chairperson, Deborah Levine, who, with the committee members, Abena Smith, Dr. Ikenna Achebe, Karen Diggs, coordinated this event, along with our partners, Manhattan Community Board, 10, 9, 11, 12, Harlem Hospital, the Department of Health and Mental Hygiene, 100 Black Men Incorporated, and Harlem Strong. I thought one of the most important takeaways is if you are an individual who are in crisis or know someone who may be in crisis, there were a lot of great resources that were shared today. I definitely want to highlight NYC 988, that hotline that can connect folks to resources. We will be sharing the slides. As you know, Dr. Sharif and the Harlem Hospital team shared all of the access. If you joined late or you weren't able to see the full recording, we will get that out to everyone who registered for the event. Additionally, any questions that were not answered will be answered in the documents that are sent to you subsequent to this webinar. I'd like to wish you all a very good day. Please, if you haven't finished, please fill out the closing poll, and I wish you all a good rest of your day. Thank you for joining us this afternoon. Goodbye.
Thank you, everybody. Have a great day.
Thank you, everyone. If we
Thank
could
you.
take a few minutes to finish out the poll, you will also be eligible for continuing education credits from the public health sector. You'll see that information will come along with the follow-up email. So thank you again. We appreciate it, and we will send out the post within a couple of days. Special thanks to our moderator, our chair, the hospital, and all of you for joining us today. Thank you and have a